Let's discuss the challenging case 33. Now look at the anterior segment of this eye. Well, this case was diagnosed by almost every viewer who commented. It's a sunset sign by IOL in the sulcus displaced inferiorly. Everyone picked that. There is also PI at 9 o'clock. Now, what can be the cause of this inferior displacement? Well, there are many causes we will discuss in detail. Trauma can damage the granules, can cause annular dehiscence. Pseudo exfoliation is a disease in which granules are already weak and they can be damaged, and IOL can be displaced inferiorly. Then during surgery, intraoperatively, if large posterior capsular rupture occurs, and one haptic displaces into the vitreous, it can also pull the intraocular lens inferiorly, and sunset sign can be seen. IOL decentration have many causes. Now, if you implant foldable single piece IOL in eye without intact capsulorhexis, when you were performing capsulorhexis, it was not round, smooth, regular, and there were many cuts. Then that bag will not keep the IOL in place. So the chances of IOL decentration will increase in such case. Another cause is the placement of one haptic in the bag and one in the sulcus. Now, in such situation, not only decentration but tilting of the IOL also occurs, and the patient experiences astigmatism, glare, photophobia, diplopia. Other causes already mentioned due to inadequate granular or capsular support are pseudoexfoliation, inferior dislocation of IOL through an unrecognized granular dialysis is a serious malposition termed sunset syndrome, which is shown here. Now, IOL decentration can cause decrease of vision, diplopia, double vision, glare, photophobia, astigmatism, and it can also induce inflammation and glaucoma if the lens is mobile. Sometimes decentered IOLs are asymptomatic when they are static and they can be observed safely, while other times they cause above mentioned problems and they need management. Now, if the problem is only double vision and glare, then constricting drops like pilocarpine may solve the problem. Observation is the best when eye is quiet, there is no inflammation, no raised intraocular pressure, IOL is static, and no VR complications. If IOL is mobile and patient symptoms are not relieving, then we have the options of redialing the IOL to the position of maximum support and bringing it in the center. If the IOL is damaged, the haptic is broken or optic is damaged, then it could not be repositioned. Then you have to perform IOL removal and exchange. And you should exchange it with large optic haptic in the sulcus, and according to the support, or if there is no support, then scleral fixation is another option. Now let's come to this case. In this patient, the patient had pseudoexfoliation, granular dehiscence with inferior decentration of the IOL due to deficient support inferiorly, and the patient was managed conservatively with pilocarpine drops. Thank you.